It is similar to Snap-on Smile.
To why? So I like to go higher.
But it's in-house
area.
Snap-on Smile. Now with this, we can evaluate patients' aesthetics, lip support, as well as speech.
As well. So we will determine that. So ideally,
So as you saw, with digital scan, any of us now can make a beautiful wax up because we have the world-renowned library in the computer, and all you have to do is copy and paste. How many of you here know how to copy and paste? So you guys qualified to make the most beautiful wax up. You don't have to spend years training yourself to be the master technician. In 2020, it's all about copy and paste. Now you can mill the PMMA, give it to the patient, you evaluate the smile line, lip support, cant, and also speech. The patient is satisfied. For example, here, I was satisfied, but patient wasn't. Patient's expectation was way higher than my skill. And she said, this smile looks too big. Can you make it a little shorter? Not a problem. We go back to the computer, we manipulate. We make it a little shorter, we mill PMMA. In 20 minutes, we have another template. But after looking at it, she realized, you know what, your previous work was better than yours. Now we have gained patient's trust. And I simply put the previous case back, and now she is super happy. Now, before you marry the patient to the case, it's very important to know patient's expectation. In 2020, you can do this easily with digital dentistry. So as you can see, it makes a big change in her smile, in her confidence. Today, she cannot go outside to her work with previous smile. And she is saving a lot of money to do full mouth reconstruction because it's not because she's rich, it's because she values dentistry. Now she was able to preview what we can do for our patients by doing simple digital wax up. And we do this routinely when patients have collapsed vertical dimension and they want to have much better facial support. All we have to do is digital wax up, and we deliver the PMMA to the patient, and you evaluate the aesthetics, speech, vertical dimension, CR, and this is the best way to do a wax up in 2020. So what are the common mistakes when you are doing a full mouth therapy, where you're changing vertical dimension, or even when you're doing orthodontics? Same concept applies. Number one, most common mistake that we make, we do a beautiful wax up. However, when we give it to the patient, he has occlusal cant or midline is not on. Second, incisor position is the key. Depending on where you place number 8 and 9, the central incisors, patient's lip support, their speech will be altered. And it is very important to place the incisors in the correct position. And we'll talk about that in more detail. And also, how wide is the maxilla? The transverse width is very important in determining vocal corridor and the full smile. Gingival display is very important. It's not, in 2020, it's not only about white aesthetics, but also we have to consider pink aesthetics for the patient. And again, we have to also consider skeletal discrepancy. Is patient class 3, class 2? Then how can we camouflage the case to convert the class 2 patients into class 1? Or how do we convert class 3 patients into class 1? Then, number 6, mandibular position. the CR position is very, very important in determining health of TMJ and also in comfort for the patient when they are chewing. And lastly, vertical dimension is very, very crucial for facial aesthetics as well as function. So number one, let's talk about occlusal canth. Now, as you can see in before photo, this patient went to many dentists in New York. Unfortunately, patient was never satisfied regardless how good of a job a dentist do. Why? When he smiles, he saw the canth. And nobody was able to fix that because his sinus was very pneumatized on the left side, and if you do ostectomy, you are into the sinus. And because he was low income, also financially it was not possible, he flew down to San Diego because in San Diego we have live surgical course. We offer almost free implant treatment to low income people, and we did sinus lift, ostectomy, and all on 6 for the patient. Now he has a beautiful smile without occlusal canth. But how about patient is not internal dentition and patient has occlusal canth? Many of my orthodontic patients have occlusal canth, and before it was very difficult to fix. Today it is very easy to fix by placing one mini screw. By placing one mini screw here and retracting with cross-port spring, we're able to correct the occlusal canth. Patient accidentally lost the bracket, so I instructed patient to take off the bracket for the local dentist and remove the bracket, and she came back because she was overseas for 2 months. When she came back, I saw the power of this tiny mini screw correcting occlusal canth. And this is done routinely in our practice. And as you can see, the control, the tooth that was not bracketed, stay in that position, and whole maxilla was able to move. Whole maxilla was able to be intruded. So very, very powerful tool. Again, when patient midline is off and patient has occlusal canth, by utilizing mini screw, you can correct the midline as well as occlusal canth. So if patient is terminal dentition, you could do it with surgical approach. If patient has teeth, then we can take orthodontic approach to correct occlusal canth. Even if they have a beautiful tooth, golden proportion, if patient has a canth and doesn't have a symmetry, I don't think we're doing good service to our patient. In 2020, orthodontic is very easy. For me, when I practice orthodontics, placing brackets on a molar was quite challenging. But in 2020, everything is done through computer. In fact, through simulation, I can even see the future outcome. Now, we are all implantologists, we use surgical guide, and I truly believe that surgical guide is the standard of care in 2020. If you are practicing orthodontics, if you don't use indirect bracket transfer, you're not practicing to the level of standard of care because this is the best and most accurate for our patient. So facially and prosthetically driven digital implant surgery is very, very important. If you are placing implant, not only consider the CT scan and the surgical guide, but you have to consider patient's face as well. Now, this patient came into us wanting a lot of implants. Unfortunately, the first thing that I realized is occlusal canth. He's a young guy. If you place an implant today in the wrong position, not looking at the face, sideways, he will have crooked face for the rest of his life. So I believe it's not only about using surgical guide, but we have to fix his jaw asymmetry first, and then plan the case driven by the face and also by the future prosthesis. So number one we did was to fix the occlusal canth. And again, today we utilize very, very tiny screw called temporary anchorage device. Diameter is 1.6 millimeter, length is 10 millimeter. For you guys, this surgery is very easy. You don't even need pilot drill. After we make an indentation, we change the angulation and we will stabilize this tiny screw called temporary anchorage device. And best of all, we can load this implant on the same day as a surgery, and we can correct the occlusal canth for this patient. And we can utilize power chain. I love power chain compared to closed coil spring because when you are intruding something, closed coil spring can really bother the lip. If you are retracting the whole maxilla, then I use closed coil spring. But again, power chain would be a better option for this type of intrusion to correct occlusal canth for this patient. After placement of TAD and intrusion, it only takes about 2 to 3 months. Now you see a huge open bite. Why? Because we have corrected the maxilla by doing intrusion. Now patient has huge open bite on the left side. After we stabilize the maxilla, then we move the mandible by doing extrusion. But again, extrusion is much easier mechanic compared to intrusion. So intrusion is first achieved to level patient's occlusal plane, then we do extrusion of the mandible. Now, because I set the maxilla in the right position, I can go ahead and place the implant on tooth number 6 where he's missing a tooth, and he's a young guy. I don't want him to walk without a tooth, so I would like to place the implant when we correct the occlusal canth. So, as you can see, patient has much better occlusal plane compared to before. Again, we're not just a dentist, but we're doctors. We should treat the face and not just the tooth. So we're going to digitally plan the surgery. And canine or anterior, always we have buccal concavity. I've seen many dentists place the implant like this to stay on the bone. But in 2020, bone grafting is so predictable. Placing implant where the bone is, it is actually not a correct method. You want to place the implant where the prosthesis go and build bone around it. So this is much proper placement of the implant where the crown exits on the cingulum. Therefore, we could make screw type restoration. We don't have to worry about cement causing peri-implantitis, just as Dr. D'Alessandro mentioned early on. Again, there's 2 ways to place anterior implant. You can stay on the bone. By staying on the bone, now you have much less favorable occlusal force, and you will end up with bone loss. Because as you can see in this photoelastic study, if you have improper angle by staying on the bone and by using 25-degree abutment to correct your mistake, you will notice facial bone loss over time because of improper occlusal force. So always aim to place the implant not along the bone, but rather where the screw comes out on the cingulum. IV sedation is very, very important because without IV sedation, I'll be scared. I'm scared to do surgery to a patient. If my patients are scared, I'm also scared. So for patient's comfort as well as my comfort, we like to sedate the patient. After sedation, as you can see, he's comfortable and I'm comfortable, and I can do the best surgery for this young man. Now, best bone graft is when you mix allograft with patient's own stem cell, and you can harvest patient's stem cell by going into the tuberosity. Due to limited time, I won't talk too much about this technique, but by mixing patient's tuberosity blood, which has tons of stem cell, and by mixing with your bone graft, you can have very, very predictable result. And the bone graft should be used in a sterile technique where it should come from the syringe. So we like to use bone in a syringe, and I only use cortical powder for my patients because I get fantastic result whenever I do bone grafting with cortical powder only. If I am doing surgery, I want to have the minimally invasive method. For my patients, I don't like to open flap. Why? When you're cutting open, you lose blood supply. Therefore, we strive to make as minimal incision as possible in the vestibule to do minimally invasive tunneling technique. By utilizing the instruments that we have developed here, we can predictively graft any type of defect nowadays with retractor. Any type of defect can be grafted predictably with tunneling technique. If you guys want to know more about the tunneling technique, we offer MIT 2-day course here in San Diego 4 times a year. And because this is a blind technique, it is very important at the end to visualize your recipient site and prepare the recipient site correctly. Otherwise, this tunneling technique will not work. Again, you want to use sterile bone. Only way to deliver sterile bone is to utilize bone in a syringe without any contamination from saliva and so on. So at the end, we can graft the site predictably through a tunneling technique so that we don't have to put the implant in the wrong angulation. Now, surgical guide, I cannot overemphasize this importance of surgical guide. Doing freehand not only takes longer time, but we are practicing at a lower level. If you want to place this implant between two roots, you will have to take multiple x-rays during the surgery with the surgical guide. As you can see, we can place the implant in perfect prosthetic position without damaging adjacent teeth. So now we have enough bone to place our implant in our prosthetic position, which is on the cingulum. Okay. Your screw access channel should always exit on the cingulum. It's a very, very important concept. How about surgical approach to correct occlusal canth? Again, we would have to do wax up to know how much ostectomy to do. So this is his temporary, and when we are missing a tooth, opposing the molars will super erupt, and after extraction, it is very important to do predictable sinus lift. And nowadays, sinus lift is very, very easy. With our latest sinus lift kit, anybody can do predictable sinus lift. And here, before we actually do sinus lift, it's very important to try on your surgical guide to see if your ostectomy is good enough, right? Because we hate to place the implant and patient still has occlusal canth. Therefore, we will check a couple different occlusal planes and do surgical ostectomy with this guide on. So sinus lift has been done. After we lift the sinus, we will do ostectomy at the same time, utilizing the same techniques that we mentioned last year. So now we have a happy patient. More than him, his wife was much, much happier.
What do you think of my new file? You love it? What do you think? Everything kimchi.
He's a little bit numb, so he's not able to.
감사합니다.